I'd like to call the meeting to order. And the first thing, I'll read our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve. Provide quality services which promotes recovery, community participation, self-sufficiency, and independence. I'll have a motion to adopt the agenda. Moved by Bertie,
Support.
supported by Dr. Hearing of the public. The public can speak for 5 minutes, and the commissioners do not answer you, but somebody from the staff will get back to you.
Good evening. My name is Dennis Bott. I'm the Chief Executive Officer at Mork, Inc. And I'm here tonight to actually thank you first for the opportunity to speak. I know there's other things you would rather be doing tonight. But last month we requested, and this board granted, a temporary tabling of the item related to the Mork rate reduction. And I want to report to you that we used that gift of time wisely. We met with the staff at Macomb Community Mental Health. We traded ideas. You will find on your agenda tonight that the rate reduction is back on the agenda. It's significantly different in that it, I think, saves, number one, saves more money than the first proposal. And secondly, it allows for a smoothing of the administrative process, which is going to help both of our organizations. And I want to express my thanks to John and to the staff at Macomb Community Mental Health. I think we made the most of this partnership, and we are happy to continue it forward. And again, I just wanted to express my thanks to the board tonight since I had the opportunity.
Thank you. Thank you. Anyone else from the public? Anyone else from the public? Seeing nobody, we'll go on with the meeting. Request to approve residential lease A. So moved by Susan. Support by Celine. All in favor?
Aye.
Against? No for Mr. Bertie. Yes, we will. Residential lease B. Can I have a motion?
So moved. Support.
Moved by Doherty. Any questions? Motion to approve? All in favor, say aye.
Aye.
Against? Recorded. C, amendment to the amended and restated ICOPI-HP agreement. Do you want to speak on that, John?
Yeah, certainly. What you're looking at here is an amendment to the initial agreement that we had signed with the Integrated Care Organization, Aetna Better Health Care. It really provides an update relative to the termination of the agreement, or the term of the agreement, I'm sorry. So it extends it out to January 1st of 2019, then also again January 1st of 2020. And it also speaks to the modifications in the rates that were provided by Aetna. When you look at PEPM, that's the per eligible per month. And, just for a point of history, when we originally drafted these contracts, none of us, I don't think on the HMO side or on our side, knew exactly what the rates were going to be and what they should be. And so I think through the efforts of the administrative staff, they were very savvy in being able to protect our interest. And I think our rates were like, $70, $80, per member per month, which was a great position to be in. And then over the course of this year and subsequent years, we're going to continue to report out our costs to the ICO, and at the same time they're reporting out our cost of the ICO, they're modifying the rates either up or down based on what our expenses actually are. And so the rate, the PEPM on page 34 really indicated that it was down to 26.81. So would you be alarmed by the fact that we were once at $80 PEPM and now we're at 26? No, not necessarily, because it's actually reflecting our costs. And then the subsequent PEPM is 36.70. And so, that's what we're agreeing to. When you peel through this on page 36, 37, it really speaks to some of the performance metrics that we have a responsibility for in the contract. So I think My Health Link is one of those projects, demonstrations that Macomb County should continue to pay a lot of attention to, because we're only a few CMHs in the whole state that are doing it. And I think that there's opportunity to improve on what we are doing. I'm pleased that 2.5 years later that we're still contracting with the ICOs, because I would have expected at some point in time if they wanted to privatize it to somebody else, they could have done so. So this is just an amendment to the agreement. I think that we're doing well relative to integrated care. I'd like to see some more clinical metrics that would support the successes that we're doing with the ICOs and the My Health Link demonstration. And I would recommend that you do approve the amendment.
Commissioner Doherty.
Thank you, Madam Chair. Through the chair to John, can you explain to me the proposed update, item 1E, which are the quality withhold? I'm reading that, and it seems like it's describing something that's supposed to benefit community mental health, but it looks like it's a drop to me. Like, it looks like 95%, like one of the benchmarks is 95% of the claims were timely received as monthly encounters, and it's been changed to 80%, which to me is lowering. Maybe I'm misunderstanding the way that's worded.
That looks the same to me too. So if the previous requirement by the ICO, and it's a mutual bilateral agreement, it's when we originally got into these ICO contracts, it was the intent of CMS, Center for Medicaid Services, to go into this initiative. And even though we are a downstream subcontractor, it's supposed to be a mutual bilateral agreement. Well, we'll take care of the Medicare business. We're going to continue our Medicaid business, and to mutually agree upon what that contract really speaks to. So as I read this, the encounter data that if 95% of the claims reconciliations were timely has been changed to 80%. It appears, on my quick read of this, is that they're giving us a little bit more flexibility in the accuracy, or the timeliness, not the accuracy, the timeliness of the claims, versus 95% of those claims being submitted. They're going to allow 80% of those claims to be submitted. Eventually, they all have to be submitted in a timely manner. But it's part of one of the many performance metrics that are in there. So that's how I would read this, that it's actually loosening the requirement a little bit.
Okay, so those are our benchmarks that have to be met.
Mutual, yeah.
Okay, well, if they're mutual, then it's giving latitude to them too. And how do those benchmarks compare with other requirements that we have in the system? Right, because I've seen audits and stuff like that where we have to have so much done within a certain time. You know what I mean? We have to have so much success rate on claims and filed within a certain. I just want to be cautious that we're not, solving one problem and creating another one.
We have oodles and oodles of performance metrics.
And I don't know all of them. That's why I'm asking about it.
Through the PIHP contract and through the CMHSP contract, the ICO agreements, and you're seeing more and more of a quality withhold. And I think we reported out to the board 3 or 4 months ago where we were the department where we had a quality withhold of about $1.6 million. So they're saying the money's yours, but as long as you perform to the metrics, then we'll give you the money back. And if you don't perform to the metrics, then you're not going to have it. We're not going to pass it through to you. And so I don't know if I'm answering your question, but this is, just one of many, many quality metrics that we do have in all of our contracts.
Okay. So it's just really, I guess maybe we could talk a little bit more offline. It seems the way you've described it that it is benefiting Macomb County, but I want to make sure, or our CMH, but I want to make sure that the flip side of it is true too, that they're being held to a standard as well, right?
Yeah.
So, I like the service level agreements. I like it when we have benchmarks, and I
Yeah.
like it when there's dollars attached to it for quality, right? Because otherwise it causes pain
Right.
for either organization. So, okay, thank you.
We've come a long way. I'll just, my concluding comment here. We've come a long way with the ICOs. They're a Medicare provider. They're a Medicare Advantage care provider, and that's what they do is they provide Medicare services. And we don't know much about Medicare, but I'll tell you, our agency is 10 times better than it was, being able to integrate Medicare, Medicaid services, and to be able to adjudicate Medicare, Medicaid claims, because most agencies can't do that. Macomb can do it, Wayne can do it, and a few others can do it. So it's a step in the right direction for the future where we maybe should be. When it comes to the contract with the ICOs themselves, they don't have any idea what Medicaid is about. I mean, it's been brutal for years to try to get them to understand what we do in the way of Medicaid services, because they want to impose more responsibilities on us. And we said, we don't do that, like transportation. We don't provide transportation. So it's been a learning curve for both the ICOs and all 5 of the ICOs and Macomb CMH as a PIHP Medicaid administrator. So all in all, I think we're far better off in better relationship with our ICOs than we've ever been. So I'm really pleased by it. And I don't believe that we're being bullied. And initially I would have said, I think we're getting pushed around a little bit by the ICOs, because you're dealing with national companies that are worth, billions. And who are we? So I think we're in really good standing with the ICOs right now.
Any other comments, speakers? I need a motion for this. Moved by. All in favor? Aye. Motion passed. D, update MCO policy 2019 community living services. There are so many acronyms here. I need a motion to approve. Moved by Bertie. Support by Serene. All in favor? Oh, John, do you want to speak before?
Yeah, sure. This comes before you, maybe some of the board have concerns. I spoke at length with Nick today. Nick has concerns about this. He couldn't be here tonight, but I suspect per his statements he'll be here at the full board meeting and want to discuss it further. The rationale is, as Kimberly indicated, our policy administrator, that we're in a better position, we're better off to be able to define health and safety than not define it. And so in the midst of what we're all familiar with over the course of the last 2 years of cutting CLS services to numerous consumers, a little uneasy about changing the policy, but I see the necessity in changing the policy, for the future, and to be able to better describe to our consumers what is covered and not covered. So the impetus of this is really around health and safety, and it's a pretty stiff definition around health and safety. And I think, Nick's not here, but I'll speak for what his concern was, that he thinks it's a little bit too rigid, but he was non-specific beyond that. Nonetheless, we continue, and Kimberly and the staff continue to try to improve our policies to make them better, to make them more understandable and congruent with the industry expectations, either through our CMHSP contract or our PHP contract. And so that's why you're seeing this as a clear, more defined definition with the intent to support consumers who have medical necessity, to have health and and safety necessity met versus try to exclude them. So we're going to have to get past that. It's not to exclude people, it's really to define and help those people who should have CLS services based on health and safety issues.
Commissioner?
Yes, under item 1B, it says that it was, the policy doesn't contain the definition that Medicare has, but it says in the Medicare provider manual, the term is undefined. So somebody, I don't know where they got this language. I don't. Somebody composed this language. As I read it, the first paragraph under health and safety, I envision all the people who've come to us in the last year saying that their services were cut and then what's going to happen to their loved one over the night. This appears, under the title Health and Safety and under the rationale, it seems to me that this puts in writing our ability to tell people that they can't live in an independent living situation. And I'm all for identifying some of those people who can't or they're not eligible for services. But this looks like it kind of seals the deal for some people who weren't otherwise had a different situation in the evaluation.
We're doing that now.
Did anybody else read this and see that it's very clear that if you can't do it,
Yeah.
you have to move, is what I'm
Yeah.
reading.
And that's what we've been doing, and we've been doing that without the definition. I mean, none of us have been satisfied with having to move folks out of independent living, semi-independent living arrangements into group homes, but we've been doing that. And we've been doing it on the pretense that historically, as we all agreed, we felt that Macomb County had a better opportunity for consumers to live independently in the community, and therefore we would provide them with supports and services, overnight supervision during the middle of the night, and we're not doing that anymore. And if the person requires something that supports health and safety, imminent risk or danger for health and safety, then we're going to continue to support that. But we've moved a number of consumers out of what we believe was the ideal and what we believe to be the closer movement towards the home and community-based services waiver, and we moved them back to group homes.
Yeah.
So what we're doing, you're right, this does provide the definition saying we're not going to provide those services because it's not defined in health and safety. But we've been practicing that way for the last 2 years without a definition.
And that's kind of what I was saying. I just want people to understand that that's what this does. It puts it in writing.
It'll help us through Medicaid fair hearings and appeals process with our consumers, because you and I and nobody wants to continue on the path that we're on, moving folks from semi-independent living arrangements into group homes. And so hopefully that will slow down within time, and we'll be able to continue to provide the ideal. In the meantime, this is the definition, so when a Medicaid fair hearing does come up or a local dispute resolution comes up, we'll be able to point to that, show that to the administrative law judge, or describe it in our policy and saying this is the rationale for our decision.
Commissioner Vosberg?
Sorry, I should have pushed my thing here. Thank you. I appreciate the fact that we have this definition included in here for some of the reasons already stated, because one of the things that we also have been hearing is our family was promised something and related to that. And I asked the question, not in a meeting, but who was promising that? And it's not necessarily that any one person was, but the impression of the family was that that was going to be something that they were entitled to for the rest of their life. And as we know, even for someone like myself, the aging process alone sometimes disqualifies you for being able to live by yourself. So I just appreciate the clarification in this. I think it will be helpful for all of us. There will be a transition for some people who didn't have to that wasn't included when they were setting up their plans of service, but it will be now. So thank you.
And if I can, just make
Yes.
one more comment too, I hope the board doesn't ever give up on the pride of what we once offered, because, we did have the ideal, and we were supported financially by the department, by the ideal, and we were very transparent, and we are closer, and we're closer to the home and community-based services initiative. When you get people from Genesee County moving to Macomb County because their services were better,
Yes.
that happened, and I still think that what we had was the ideal, and it's unfortunate it's not going to continue that way.
Seeing no other speakers, I have a motion on the floor. All in favor? Aye. Against? Motion passed. We're going on to E, MORC rate modification. I see that's a reduction, right?
Correct.
Page 56. All in favor? Any discussion?
I think, back to Mr. Bott's comment, we have been working with MORC for a long time. They're a very valued provider of ours, very respected provider of ours. You have the most difficult intellectual developmentally disabled consumers that you need to care for. MORC steps up and does so. And they've done so for as long as I've known them. We're in difficult times here, and they're a large contractor. We spend about, $40 million or $39 million, whatever, for services to MORC, and that's not to take away from, all the costs that they also have to care for in the way of their operations. But, they're leaps and bounds larger than any other provider, and I think our next nearest provider is about $9 million that we send out. We have, this board has held MORC whole in respect of not having issued any rate reductions since I've been around for the last 8 or 9 years. Meanwhile, many of our providers, most all of our other providers, have had between a 5 and 12% rate reduction. And so when we were, the MORC contract is incredibly complex, and I have to certainly appreciate the MORC staff, the administration, as well as the CMH staff and administration on being able to sit at the table and for hours and hours on end go around the complications and the technical, components of this contract. And so we're finally at that point. We're at that point where we've asked MORC to help us out. We've taken a $40 million shot on the chin, and I need MORC to help us out. And so now they're going to do that. Not that they were opposed to it, they just want to understand it. So here we are, and I think that we're within our legal contract right to be able to modify those rates back to October 1st of 2017. And the finance folks on both sides are going to be able to figure that out. And the cost savings to us is really going to be about $1.6 million. So you have to give credit to our finance staff who have taken the lead in being able to bring this about, and our business staff. I won't leave anybody out. And also MORC's receptibility to it, because it's not a $1.6 million increase, it's a decrease. But that's where we are right now. So I would strongly encourage the board to support it, to make it retroactive to 10/1/2017, and understand the complexities without them being all of them articulated right here tonight.
So all in favor, any speakers? All in favor? Aye. Motion, against? Motion passed. F, approval of care of Southeast Michigan's request to extend STR peer recovery coach program into McLaren's Hospital Emergency Department. Can I ask a question? It's that old St. Joseph's?
I'm going to defer to
I want to
Mr.
know where
O'Brien.
it's located.
Good evening.
Good evening.
I didn't quite catch the
Where is
question.
it? Where is McLaren located?
Oh, McLaren Mount Clemens.
Is that where Old St.
It
Joseph?
used to be Mount Clemens General,
Oh, okay.
the hospital, yeah.
Yeah. Okay, you can talk.
Thank you. We're asking for approval, obviously, to have care of southeastern Michigan to expand the current program that they have that is now being done in the St. John Macomb Emergency Room, and also in Henry Ford Hospital, Macomb Emergency Rooms right now. It's a service that they began with recovery. They have recovery coaches that go into the emergency rooms. It is their job to hook up with people that might have been recently overdosed and have been serviced with Narcan or naloxone. They try to engage them in treatment. They do a screening and assessment as part of that. And they also will provide support. They will, if they can engage somebody that's ready to go into treatment, they'll work on getting them in, hooked up with access, hooked up with a treatment program. We'll arrange transportation. It's kind of a catch-all kind of a thing. They actually, what they really do, probably the biggest thing is to try and divert these people from having them come back to the hospital because they've had another overdose. There was one story that they were telling me that they had a client that had been, in a very short period of time, had been in the emergency room 8 times. And they tried to hook up with him before, but they couldn't. And finally, they hooked them hooked them up with a coach who was able to get them to admit that they had a problem after 8 admissions, and then was able to get them into treatment. And it started the whole process. They were able in treatment when they got into residential, they got into outpatient. Were assigned another recovery coach at that point. We got into our recovery homes, and right now they've gone through the whole process, and now they're paying for their own way at the recovery homes, and we're not paying for them anymore. So you've got one of those very, very successful kinds of circumstances. In the first year, they've served over 1,440 clients. Not bad when they put this thing together in a very short period of time. And they had to hire 8 recovery coaches, and they were able to do that in a reasonable period of time. Because there's always that startup period that you have anytime you have a new initiative. They have about 35% of them have been engaged into treatment so far. It's been very successful. The hospitals work very closely with them. The hospital actually are, I think, quite happy to have them there because, they never know what to do with these people who have drug problems that come in the emergency rooms that take up space.
Yes.
So it's been very, very positive of an experience. They have the funding for this came out of what we call the STR, but the state targeted response dollars that were issued last year in the spring of last year. That they're federal dollars that came out of special funding. They're one-time funding, came out of special funding from the feds, specifically designed to try and reduce the opioid problem that occurs all over the U.S. Michigan got $16 million, and this was one of the initiatives. We had 5 different initiatives that were funded as part of this. And CARE, in fact, is not only doing recovery coaches services here as part of this, they're also doing in 3 or 4 different courts that are sobriety courts that are occurring over in the area. The money, there's been problems with this grant because money came mid-year, and instead of running it on a straight fiscal year, you probably don't need to know all of this, but it's on a straight fiscal year. It's not on a straight fiscal year, so you had like a half year, and then it starts up again, and then it's another half year, and it's created problems with us in terms of being able to get some of the services going and to plan for a whole year. This proposal was written originally a couple months ago, and it was to cover 6 months, and that's why you have a 6 months budget in the back of it. But we're really asking for approval of a full year for this. We know we have dollars that haven't been spent, so we'll be able to use the STR dollars for that. There's another round of STR dollars that are coming very soon. That state's getting another 17 million. Again, we had about 1.4 million in those dollars, and we'll probably get something similar to that. So there should be, and if for one reason, because there's always things that happen sometimes when the dollars come down from the state like this, because they could take some of the money out, they could use it for other purposes outside of our system. But we have dollars to cover it in either our regular block grant dollars or through our Public Act 2 dollars.
So you're sure you're gonna get the money?
We've got it covered. Our goal is to use STR dollars first, because that's, those are one-time dollars, and you want to spend those dollars first, and then we use the rest dollars. We do STR dollars, then we use our regular block grant dollars, and then we would use our Public Act 2 dollars. That's kind of the order that we would use.
Was there any questions for Director O'Brien? Susan, Commissioner?
Thank you, Madam Chair. So I want to make sure I understand this right. So people go into the emergency room with the overdose situations or drug issues. The care staff are going in and assisting and determining if they need residential treatment or not residential treatment.
Well, it's Access's job ultimately. It's their job to get them hooked up with Access to make that determination. And they're not doing it right when they come in the hospital. They got to wait till they get stabilized a bit.
No,
Okay.
I apologize.
Okay.
I'm oversimplifying it. I understand there's a lot more to it than that. But, or I can imagine it because I'm not a professional in that area. But do these clients ever go through the UBHC? If they're not going into residential treatment, do they go there? Do they go to the UBHC?
They typically
for
don't go to
follow-up?
UBHC, but there are many places, many ways a client could come into our system.
Mm-hmm.
And I know that there have been some clients that have gone through UBHC, and then they have their own system of hooking them up. When it comes to the recovery coaches, just so you understand, because we have regular community recovery coaches. Now we're starting to label them. We depending on where they're at. But we've had those established since 2012, and there's about 8 in the community for that. So we get once they get into treatment, into any of our providers, we try to hook them up with a recovery coach. So that, because they're people that have been through this before. They're people that have at least 4 years or more of recovery. So they've been through it before. They know the system. They help people navigate the system. They help them find other supports that they need to have, hook them up with AA groups, NA groups, and that sort of thing. So it's a win-win. We're finding that over time, is that we're keeping people in treatment longer than we used to, since we've had recovery coaches. And that's what we want to do, because the longer you can keep somebody in treatment, the better chance you have of long-term recovery.
Okay, and I don't disagree with the success of the program, and I know that the recovery coaches are amazing at helping people because they've walked the walk, right? So I get that, but I'm just trying to make sure that, we're retaining care to do this service for our, potential clients, and that they're getting, I know that they're getting the wraparound services that they need I'm just trying to say if there are services that they need, that they're utilizing services that we already have under our roof. I'm just making sure that we're providing whatever referral and RAP services that we have that exist under our own house before we go seeking them elsewhere. That's my question.
Yeah, okay. To the best of my knowledge, that is in fact happening.
Okay.
And one of the historical things about CARE is CARE was our access center for 40 years for substance abuse services until we switched them over after Public Act 500 was passed. And so they're very familiar with the services. And now they've become, you had to find this void. They had to find a void to fill.
Right.
And we started it with, we had Project Vox, which is an advocacy organization for people in recovery that was housed there. And it kind of started there, and then we started building when we started doing the recovery coaches. And I could give you a whole history of stuff that you probably don't want to know, but we involved our entire network when we did focus groups to ask when we set up the recovery coach, and had brought in providers, brought in people recovery, brought in people from our advisory board at that time, and asked for their input in terms of how should we set this up. And the main question that we came down to was, do you want to have recovery coaches at each program, or would you rather have it be at a centralized place where they can follow the client wherever they go? And the group came up with, yes, we want to have a centralized program, and we want CARE to do it.
Okay.
So, it works very well. And they're pretty well integrated, and CARE is involved in a lot of ways, and it's an excellent provider. So.
Okay, thank you.
Commissioner, sorry, then Linda.
Randy, I'm familiar with your services, and I know the emergency room departments greatly appreciate everything your staff do. They do work very well with the consumers there. But what about the consumers that aren't medically clear that end up on a medical floor and still need the same services? At some point, will you ever be considering for us to contact you to see a patient on a medical floor upon discharge?
Well, CARE isn't just in the emergency room. They will go anywhere in the hospital to meet with somebody. So if somebody shows up in somewhere else that there's an issue and that somebody wants to make a referral, they'll go up to them and talk to them.
Okay.
In fact, one of the things that we were talking about doing too is we have some mental health peer supports in, I'm not sure which hospital, I think Henry Ford, and about having them interface with our SUD people so you can kind of work back and forth on that. So we've had some initial discussions about that, so that we're working together, and you get the co-occurring people and work on that way. So
Okay,
that
thank you.
answer you?
Commissioner Bush.
Well, McLaren is my emergency room, having been there 3 times last year. And when I was there, I asked questions. Why is it like this? Why is the wait 10 hours? And they said because of mental health and substance use, patients using the emergency room. So I'm sure McLaren is happy to have you there. And,
what I hear is they're very anxious to have them come in, and they may in fact be the busiest of all 3 of them. But
good.
Well, thank you. Any other questions? I need a motion, don't I? Yes. Do you have a daughter here? All in favor? Aye. Against?
thank you.
Motion passed. 6, resolution, CMH employee retirement. Sandra Luther, Specialist Residential Services. Should we let her retire? So moved. Other agenda items. Oh, a motion for retirement? Do I need a motion?
Yes.
So move. Okay, we have the motion. Aye. All in favor? Aye. Against? So move. Other agenda items. Our director, executive director.
I don't want to jump in front of anybody else. Quite a few things I just want to throw at you really quick. We had a community forum on June 2nd. A beautiful day. The attendance wasn't quite what we wanted it to be. We did it in partnership with the Alliance for the Mentally Ill out of Oakland County. I'm sorry, sure. So we did the forum was in cooperation with the Alliance for the Mentally Ill out of Oakland County. Very small attendance, but some great discussion just the same. Anybody who attended, I'm certainly believe that they came away with more knowledge than what they had when they went into it. Representative Yanez was there, very receptive to many of our thoughts and what we had to say. What was striking to me is when you think about We have 4,700 direct care workers in Macomb County, and all of them need wages. Out of the 4,700, zero direct care workers showed up. Our providers, and I'm not being critical, I'm just being pointed to. I mean, when there's a time and opportunity to get your legislature and speak about money, recently we provided increases to a couple of providers, and we've decreased rates to everybody else. 2 providers. We have 360. We had 2 providers show up. And I think that when we have these forums, if we're going to continue to have no momentum and make the system better, we got to have that voice, and we got to have that voice all the time. So that was my takeaway. But overall, I thought the forum was very well conducted, and absent the turnout, very well received by Representative Yanis. Also, for your awareness, you always get the PIHP contract, our Medicaid contract, the $170 million contract. We always get that in like August or September, and you got to sign it. You're going to see that in 2 weeks. The department has sent us the PIHP contract, said that we have to execute it by June 30. So I just got it yesterday. I'm going to bring it to the full board. As per the usual, doesn't have any rates attached to it, but the expectation that we all sign the PIHP contract, and I will give an overview of that. I would suspect that the CMH contract is right around the corner. Usually they send one out, and 2 days later I get the next one. So you can expect on June 27 to, I don't know if my mic's working, on June 27th to see the PIHP contract, perhaps even the CMHSP contract. Our finance department is working with the county auditors. I think we survived our audit with the county auditors. I haven't had a chance to catch up with the CFO, but they were in, and it's usually a pretty intense time for some while to be able to reconcile what we do and what they understand we do. And so my understanding is that the auditors are gone, and there's no lingering issues relative to our financial reporting. We will report out, I wanted to do it today, but we will report out the second quarter FSR, Financial Services Report. And so that will come a mid-year. I think that's the mid-year. I'm just saying second quarter, the mid-year report. So I have that in file, and what I'm going to do is I'm going to provide the executive brief to you. I wanted you to be able to see it ahead of time. So we'll upload it into Board Sync on June 20th, next Wednesday, and then we're going to run through that executive brief that'll spell out where we are with Medicaid, where we are with Healthy Michigan Plan, General Fund, and the combined Medicaid and Healthy Michigan Fund budgets. As you know, the House passed, and I believe the Senate passed today, the $1 million. We've been after $7.5 million for 2 years, $12.5 million for 2 years. We got one. So recently, of all those efforts, and everybody, you may have some differing opinion, and I'm not going to speak to where you're at with it, but there was under endowment fund or some category along that line that we're going to get $1 million for Macomb County in smoothing, the smoothing dollars, not the 7.5 that we asked for. So $1 million is in there. Just as a side note, Lakeshore LRE, which is good that the state didn't bury them and bring in an HMO. The state actually offered up to LRE $6.7 million. So they got kind of what we got last year. So you'll see $1 million for this year for smoothing dollars. So collectively total out of the 12.5 we asked for, we got 6. I don't think we go any further. I mean, we can talk about this again, but I don't think we keep ringing that bell. Now it's just a matter of being able to manage revenue to expense. You know, we went at it twice. I just don't think we go at it again next year, but we can talk about that at a later point in time. The DAB migration that we're all aware of, you know, Milliman indicated, and they pretty much came out and said that the statewide PIHP has lost $120 million, and the DAB, you know, who turned HMP, who turned TANF, and they're going to offer up, and they have offered up in the House bill, $59.8 million, $59.8 million, so just shy of $60 million bucks. And there were actually some winners and some losers, what I understand. that some people, even though they experience DAB loss, their rates are going to go down. We're not one of them. I think we're in the around 7.2, 7.4% increase on what we're going to get, and I'll bring that back to you as well too. If that stands true, we will receive Medicaid dollars on July 1, August 1, and September 1 for Medicaid eligibles enrolled in Macomb County that will support some of that DAB relief, that DAB migration relief. So maybe about $4.2 million. So you got the $1 million in smoothing, which is really needed right at this point in time, the $4.2 million in DAB, and based on your actions tonight and hopefully adopted by the full board, you're going to pick up another 1.6 million from MORC. So you're picking up around $7-8 million, which is critically important. Then you're going to realize how important that is when we report out the budget on the 27th, and then in the subsequent two reporting periods in August and then in November. I think we're in pretty good shape. We need to control our acute psychiatric inpatient services. That's just grinding away at us, and really maintain our general fund expenses that we're experiencing. But I'm feeling more and more optimistic. It's up and down. It seems like some days about where we are financially. But you have to preserve the financial integrity of the PIHP to continue to be able to do this business. And at the same point in time, be sensitive to the reductions to the consumers, as we always have been. There was Linda Bush might want to speak about this a bit further. There was a considerable amount of money, $64 million, reduction in the autism benefit, and how that's going to play out. We're going to have to wait from the department to tell us, how those funds are going to play out, and if we're going to have to work with our providers differently on different autism rates. Section E of 298, through the advocacy of the Board Association and everybody else at large, they removed Section E. That was one where it allowed the HMOs in the future marketplace to be able to not contract with CMHSPs. So everybody's doing backflips over that. Just as a point of reference, that there's a current ORR investigation going on right now about Macomb County, myself, and neglect for the executive directive that was sent out that we're no longer going to purchase and pay for people's spend down amounts. So that investigation is going to go on probably for the next couple of months. So when it's concluded, obviously you're going to get a report on the findings of, do we stand just and were we correct in our implementation in no longer paying the spend down for consumers, which we all believe. We're just with that, but we have to get through our defense with the recipient rights investigator. So that's ongoing. I did pass along to you, it was really interesting, read the federal lawsuit that was filed recently against the department. If you haven't read it, read it. I mean, it's really interesting. And when I was reading, my wife was sitting on the couch with me, and I'm waiting for Macomb to pop up, as I'm reading this. I mean, we got to be in here someplace, and we weren't. So I don't know if that's good or bad. We weren't a defendant in that lawsuit, but because it's a class action, we were more siding with the plaintiff. But it does tell you the incredible challenges of being able to deliver services to very complex, needy families. I don't mean that in a bad way. I'm just saying they need a lot of services. So I think there were 7 or 8 CMHSPs that were cited for failure to be able to deliver the services. A lot of it was network adequacy, or provider network adequacy. But it's kind of like, whew, it wasn't Macomb. Could just as well be Macomb. So if you haven't read it, take your time and read it. It's about 60 pages. It's an interesting read. It tells you the weight and the challenge of being able to try to meet the needs of the consumers. So take a look at that. You want me to resend it, I will. And the last thing too, it's not easy to. We have one of our staff persons just recently who had a very serious medical near grave condition. She was vibrant, just really an exciting person, worked for us for a long time. And, your thoughts and prayers that she's not doing well.
Is that it, John? I'd like to say that Commissioner Phillips and Commissioner Bush and myself attended the meeting on Saturday at Macomb. Very poor showing, very poor. Commissioner Bush?
Well, I'm not sure what's appropriate, so I'm thinking, but I'd just like to make a comment on the budget that was passed yesterday, and there's a lot of different information coming to us from the Board Association. I don't know if all the board gets that, but in terms of the analysis, I have asked Alan Bolter it appeared to me, I don't know for sure, but at a quick look, it appeared to me, I'll call your attention to the House Cares report. The State House went around and we cooperated and helped and facilitated, and parents took their children, and people went and testified and gave them all this information. Then they did the House Cares report. And when I read it, it was like, wow, they appear that they really got it. And they made a lot of recommendations for a lot of things that would really help our clients. But I said, are they going to fund it? It's nice to at least recognize the situations that people are in and come up with some really good service programs and ways to address those. It doesn't appear to me that many of their recommendations were addressed. I have asked Alan Bolter to give an analysis if it was, and I will probably come back to this board asking that if they're not, that maybe we write a letter to the chairperson of the House Cares Committee that how disappointed we are as a board that they didn't act to fund their own recommendations. And along that line, I think at some point, John will probably be doing a report. We all know that all the work that different legislators did on our behalf. It's been over a year trying to get this 7.5 that turned into 1 million, which is, a pittance, considering they cut us 40 million. So I have a lot of feelings and comments about that. Today's Macomb Daily had 2 representatives talking about how Macomb was cheated in the process, and that mental health and substance abuse was not considered well in the budget. My own representative was very instrumental in getting us the 1 million, so that was good, I guess. But some way that we thank them for their support, even though they weren't as successful as we had hoped. But Henry Yanas and John Churkin are quoted in the Macomb Daily saying that Macomb has become a donor county, in that with the opioid crisis and all the emphasis, everyone's saying, oh, deal with mental health, and then they don't choose to fund us and treat us like a stepchild. So those would be 2 things I'll probably bring up at the full board.
Thank you, Commissioner. Any other speakers? Seeing none, hearing of the public. You have 5 minutes to speak. The commissioners will not answer you, but staff will get back to you. Anybody from the public would like to speak? Anyone from the public? Seeing nobody, the meeting is adjourned.